Thank you, Brother Mel, and good morning to everyone. To Flo and Ed Waits, a special hello. It's great to see them again. And since the conference last year, Ed has received a doctorate award, and so I want to congratulate him on that and tell him that it's an honor to be part of his the annual lectureship. Respiratory care and pulmonary medicine, hand in hand. I could, without my nurses, without my respiratory care practitioners and professionals, I could not have taken care of any of my patients. So I knew that I wrote the orders and left, and if my patients got well, it was due to you all and to the excellence of your care. So first of all, thanks to all of you who have come under patient care when I was present, or part of your family that I might have even treated. So it's a wonderful thing to be here and to be part of this. Last year we had an epidemic, not a pandemic, but an epidemic. And I want, as we go through and speak of influenza, I want to give you some definitions that will help you, that you need to know when you speak to patients about influenza. And let me say this, you all in the fall of this coming year, you have a great opportunity and a responsibility to teach your patients the critical importance of vaccination. And I'm going to spend some time on vaccination, not only against influenza, but against those things that follow it, the way a shoe is put on a foot after that foot hits the floor in the morning. And I'm going to reveal to you some things that are so closely tied that we used to follow the course of influenza across the country by the number of deaths in old people from pneumococcal pneumonia. So we're going to look at the types, influenza A, B, C, and D, the nomenclature, how they're named, and why it's important to know about their naming, because that teaches us something about the nature of this virus. This is an RNA virus, not a DNA, but an RNA virus, fairly simple, but highly aggressive. How we recognize it when the fall comes and we have a 2 to 3 month period when we're going to see influenza in the community, among our patients, in young people and in old people and in special categories of people in particular. And since you're dealing with those who have respiratory and cardiac problems, pulmonary and cardiac problems, you're going to see a lot of them, and their families are going to be exposed, and you're going to have to even know how to counsel them about how to prevent disease or treat early disease. How it manifests itself, what are some unique clinical findings? There are some things, there are many viruses that cause respiratory illness, and you all know that fully 85 to 90% of the acute upper respiratory illnesses that sometimes progress down and include bronchitis and or bronchiolitis are caused by viruses and are not treatable by antibiotics, but there are certain particular associated illnesses where we have to liberalize the use of antibiotics, and I'll emphasize that. I want to talk about the recent epidemics and what the difference is between antigenic drift and antigenic shift. Okay, and that's going to be important. You're going to need to know these definitions. This is a little look at it. It's a pretty simple looking virus. There it is. There's a viral particle right there. One of those little boys right there can get into one of your respiratory lining cells, usually the ciliated columnar cells of your trachea and upper airway, the bronchi, and it has the ability, because of some things that it can attach to on your ciliated cells, usually the ciliated cells first, and it starts elaborating some enzymes that allow that little virus right there to be enveloped by that cell. And then it begins to replicate, and after it feeds on the cytoplasm of your cell, and after it replicates, it ruptures and thus becomes viral spread from cell to cell and into the airway, and it's carried away. So it looks simple. There it is. Now, what I'd like for you to notice is these projections here, and they're complex. They look fairly simple, but there are many things. These are antigenic sites. If we can figure out what the mucoproteins and glycoproteins on the surface of these look like, then we can make a vaccine against that, because these are attachment areas, and so we target those when we develop a vaccine. Now, there are 4 influenza viruses that have been known to transmit disease that we can categorize. A, B, and C cause human disease. Does D, which in 2011 was found, does it transmit? We're not sure. Maybe an occasional, but for our purposes, we're going to focus on the most virulent human strain, which is influenza A. Now, when an epidemic occurs, like occurred last year in our community, we saw predominantly A, but there will invariably be a few cases of influenza B. We don't name them. They're not complex. They're not as virulent. They do not tend to undergo antigenic drift every year, so that some of the proteins are reassembled and resorted a little different, so that a vaccine doesn't recognize them quite so easily. So B is a milder disease. It mutates at a much slower rate, as you can see here. Most people have had exposure to influenza B and develop immunity at an early age. Interestingly, there's some animal reservoirs, and it's been found in seals. B has. But A is what we're going to focus on. C virus infects humans and pigs and can cause severe illness and local epidemics. Now, swine flu is not due to influenza C, however. Influenza A is responsible for what, and I'll define swine flu a little bit more, but pigs and humans do serve as a reservoir for this virus. Let me say this: in the temperate zones of the northern and the southern hemispheres, influenza is a disease of the fall and winter months. However, in the tropics, influenza exists year-round. And so it probably is just transmitted slowly in the tropics. And that's a reservoir. People in the tropics provide a reservoir. And now that we have worldwide travel and communication and medical teams going in and out of all third world countries, it may be that as influenza exists in humans and in some of their animal reservoirs, that's why it keeps coming back every year. Almost every single year we will have some spike in the number. Now, an epidemic is defined as so many cases per 100,000 population. Last year we did reach an epidemic. We did have an epidemic, and interestingly, last year's influenza, which was an H3N2, and we'll talk about that, what that means in just a second. It attacked healthy people and children in particular. And there were over 265 deaths in this country despite neonatal critical care among infants who developed influenza. So it was a bad actor. The vaccine that we had developed the year before, you never have a vaccine that year at the beginning of the influenza. It's always last year's vaccine. It was only about 40 to 60% protective. However, let me say this. The reason, if someone says to you, and you're teaching someone, and they say, well, I hear that vaccine's not, it's not going to protect 100% of people. You say, oh, no vaccine does. But let me assure you this, it's the most current. It will give you some protection, 60 to 80%, almost invariably in population studies. And even if it isn't totally protective, it will lessen the effect of your influenza on you. In other other words, you're less likely to have it progress to a severe viral pneumonia with adult respiratory distress syndrome and death. So you must teach people, yes, no vaccine's 100% effective. It depends on your immune system, the time you get it, the time of your exposure, even the amount of inoculum. If you've been vaccinated and you just have a casual exposure and the person just is shedding a little bit, they're, say, second week into their illness and they're just shedding a few viral particles, you're less likely to have a severe case. You may just have an upper respiratory infection, not even go and be tested by a rapid method, so that you don't even know it's influenza. So remember that it's important that vaccination, that you understand what it protects, what it does, and how it lessens illness. Now, here's the look at this is the surface I was talking about. These little knobs where neuraminidase and hemagglutinin, HN. So we name the viruses after we encode them. We name them by this, the HN nomenclature. The hemagglutinin neuraminidase. Okay, you don't need to remember those long names, just HN. Now, this is an influenza A. This is the only one that we type like this. This tells us where it first appeared and was identified. And this says this is a Fujian origin, from Fuji. This came from Fuji. We always have a number of everything. You all know that. 411. The year it was isolated, very important. And then this. Okay, now, the drug companies take a look at the year we isolated and the viral site. And as soon as we can get this information to them, yes, we have an A that is an H3N2. They begin making a vaccine as specific against that as possible. Now, as there are 16 genomes of the hemagglutinin particle identified sites, 16, and 9 of the neuraminidase, but only 1 through 5 and 1 through 3 have ever been identified with human disease, and that's a blessing. Okay, we so far, you know, all the epidemics have been confined to H1, H2, H3, H4, H5, or N1, N2, N3. No more than that. Okay, combinations. Now, let me go back to the worst epidemic that we ever knew worldwide. Pandemic. The difference between an epidemic, which is a local outbreak in a country, it may spread to another country, but it's not a pandemic. That is, we do not have multiple countries involved with an infectivity rate greater than 20%. In 1957, I graduated from high school in 1958. In 1957-58, we had a pandemic across multiple nations, and in America, in urban areas, approximately 50% of the population was infected. That's a lot of people to be exposed. So that defines pandemic worldwide. Epidemic, local, large numbers in local locales that are identified, but not worldwide. Now, with travel the way it is, and with closed space and airplanes and recirculation and so on, certainly you can have a person in China who's infected and who can bring it to America. So we do see spread fairly easily. Now, let me just say then, influenza A is what we worry about and what we type. We always name where it comes from. We put a number to it. The year is important. So I mentioned 1918, severe. That was an H1N1. That's when it started. We started typing it, and we went back and actually had sera and things saved. And when we were able to type it later in the 40s and 50s, that's when we knew it was an H1N1. Okay? So you come forward from 1918, come all the way to 1957, an H2N2. Okay, then 1977 was an H3N2. H2N2 also, and then this last year we had an H3N2. So that's not important that you know, except that it's shifting and changing. The site, the antigenic site, hemagglutinin site, is able to reassemble itself and rearrange its amino acids which make up the protein, glycoprotein structure on this surface here, on this little knob, and fool vaccines by just the reassortment. Okay, so here we see that the pandemic is affects the world population. They occur, 9 in the last 300 years. So every 9 to 10 years, we'll have a larger outbreak than local. The Spanish flu pandemic was the worst. You see it killed from 50 to 100 million people. Now remember, there were no antivirals then, and we really didn't even know about, of course we had no antivirals, therefore families were not protected when an index case in the family got it. It was like tuberculosis before we had effective drugs. If an active case of TB lived in your house, you had 40% of the people who lived there were going to convert their PPD, and 20% of them were going to go ahead and develop active tuberculosis. So there have been about 3 influenza pandemics in each century, the most recent being the 2009 flu pandemic, which we called swine flu. And there was avian, swine, and human influenza particles that reassembled themselves into a virulent influenza A during that time. This is, I'm not going to spend any time with it, except I'm going to come to this. Unlike most strains, H1N1 does not disproportionately infect older adults. It affects healthy, previously very healthy, and children during the first 2 years of life will be killed by an H1N1 influenza virus very quickly. That's the main thing, and I'm going to talk about this. The New England Journal of Medicine does recommend that when a patient's chest x-ray begins to change and shows infiltration with a case of influenza that we've typed and say this person has influenza, now they improved for a while, now they're coughing more, their fever has gone back up in a bimodal fashion. They've had 2 to 3 days of fever. Fever went down for 2 or 3 days. Now the temperature is coming back up. The cough is increasing. They begin to feel weak again. We take a chest x-ray and now they have infiltrates. The question is this progressive viral influenza pneumonia, or is this because the airway has been damaged severely? Is this a secondary commensal in the upper airway, H. influenza, Streptococcus pneumoniae, or staph even, that is now causing a bacterial pneumonia? So the recommendation is that when infiltrates begin to appear midway in the course of influenza, that antibiotics and antivirals be used, okay, together. So that's not over-treatment at all. Let me say this. Obviously, the pneumococcus is going to cause most of the cases of pneumonia because it's most prevalent. However, of all the diseases that cause staph pneumonia, it is influenza. We see more staphylococcal pneumonia. Why is that important? Because staph eats the lung tissue. It causes necrosis of the lung with cavities and hemoptysis and pneumothorax, spontaneous pneumothorax. So it's a dreadful complication. It usually presents in the bimodal fashion after influenza looks as if it may be getting better. All of a sudden the fever goes up, cough increases, sputum becomes bloody. We culture staph, and if you send a white count off and it's very low, it is a key that this is likely staph. Even before it comes back, if the white blood cell count is like 2,000, 1,800 instead of 18,000, which the pneumococcus causes, okay, then you suspect staph and you treat with a drug that will cover both pneumococcus and staphylococcus. Very important point. Here's just a quick look. You see that the blue is the H1, AH1, H3. This is in 2008, 2009. This just shows you just a little of the distribution. So we have an infectivity rate of about 22% in 2008 of the population. Remember in 57 I said fully 50% of Americans in urban areas were infected in 57. How about last fall? Well, we had a new formulation. It was an H3N2, which we had not seen before in a long time. Therefore, the vaccine that was against H2N2 and included H1N1, and the vaccines have a mixture of things we have seen before. It was not expected that this would be the combination. This is the first time since 2015, and therefore, this reassortment, this antigenic drift had occurred and had actually become a shift over time. Now, let's talk about that. Here's an H1N1. It's an H1N1, let's say 2005. And in 2007, it's still H1N1, but it's different, and the vaccine is less effective. And then a couple of years later, still H1N1, but the vaccine even less effective because it's reassorted. Then it goes from an antigenic drift to a shift, and suddenly from H1N1 it's H3N2. That's the antigenic shift, and you must have a totally new vaccine to be effective. We know that the CDC reported, actually it ended up over 250 children died in last fall's epidemic. 165 was the last report. Well, you know how it presents. Most of you may have had it. You've treated patients with it. You've had it in your family. But let me go over some clinical clues, some things that separate it a bit. Now, in children and in young adults and in the old people, so both extremes of age, upper respiratory illnesses are caused by rhinovirus, the common nasal virus that causes a cold, by human respiratory syncytial virus, particularly in the young under 2 years of age. Almost all cases of bronchiolitis are caused by RSV, human respiratory syncytial virus. The coronaviruses cause respiratory illness, and we had a severe one called SARS, S-A-R-S, severe adult respiratory syndrome virus. Thank goodness, only a few hundred cases were reported. It was limited to Hong Kong, China, and so on, and it never really made it to this country. 25% of those people died who got it, and so on. So we go on through those, even the adenoviruses. Before I name adenovirus, let's look at parainfluenza. This is an important one. Parainfluenza. It's like influenza. Both in young people and in infants can cause a croup-like syndrome. Now, when an infant develops, quote, croup, with this high brassy cough, we must think of three things. Do they have epiglottitis from H. influenza, which must be treated with an antibiotic? Haemophilus influenza is an epiglottitis. We have to get a look at the epiglottis to see if it's swollen. Or is it just a laryngotracheal bronchitis that involves the cords and they're hoarse and the cords are swollen and the cords are causing this brassy cough, and the epiglottis is red, but it's not swelling up as if it will obstruct the airway. So we think about, at that time, we think about RSV, epiglottitis, or finally, is it influenza just causing a croupy cough? Well, the headaches with true influenza, both A and B, is a prominent, the headache is. Now, it can either be frontal or global over the whole thing, but here's a unique part of it. There's pain behind the eyes almost always with influenza. Feeling of retroorbital discomfort. And when you ask the patient, you're just there talking, putting oxygen on them, doing whatever you're doing to them, and you ask, does it hurt particularly for you to turn your eyes laterally to either side? They shake their head, oh yeah, I don't do that. And you notice, you say, well, here, let me take a look at your eyes, and you take a light, and they say, no, I can't stand the light. So they have photophobia, pain behind the eyes, pain on lateral movement, and the eyes water profusely. So that's influenza causes that. So that's something you look for. They have a runny stuffy nose. They have starts many times with a dreadful sore throat. The aching, the muscular aching, is particular in the legs and in the lumbosacral area back here. Now, there is, well, I'll wait till we get to the extrapulmonary manifestations, but the legs, calves can be extremely tender and can get swollen and and boggy. So this is 90% of people have this, with sudden onset of fever so distinct that usually about 80% of patients who develop influenza can tell you the date, the time within an hour of when they started feeling bad. There is a viremia that occurs and they feel lassitude, they feel weak. They can develop a headache, and they can name it, and that's very important. Do you know? And if somebody's working beside you and they say, you know, I've had the flu 2 or 3 days, and I'm just dragging and so on. Well, I don't hear you coughing. No. Do you have fever? No, no fever. But I mean, I'm sure I've got the flu. Well, if they don't have fever, they don't have a headache, and they're still working, highly unlikely. The influenza goes boom. And it's there, and it appears rapidly. They cough excessively for 2 or 3 days, then the cough begins to subside. And like I said, you want to know where they are. Initial mode, when you see them, are bimodal. That is, they got better, and now something else is happening. And that's the key, the warning that secondary viral pneumonia or bacterial pneumonia has occurred. This was cut off. Gastric distress. Children have GI problems with it. Adults, the GI tract is relatively uninvolved. You have no appetite, but nausea and vomiting are very uncommon. But in children, it's reasonably common. Okay, so we've talked about this when we have them look side to side. The aching, large muscles of the back, posterior chest, sudden onset, fever, 101 to 103, very common. Here we have, this is important. The cough, after you've quit coughing breath after breath and can't sleep, you have cough anytime you change position or you eat that lasts for 2 or 3 weeks. And post-influenza, there are 2 post-influenzal syndromes that we have to treat specifically. One is the post-influenzal cough, where your airways have become very sensitized. The large irritant airways are so sensitized that you keep on coughing, just have this little cough, you can't suppress it, and we have to suppress it at least at night so completely that we let the epithelium heal. Now I want to tell you about that because this next point is so important. The influenza attacks, like I said a while ago, the columnar ciliated cells. In my office, I kept a microscope, and I would make a wet prep. I would have the person go into a little isolated area that had a little exit ventilation and produce just a little bit of sputum. Before we had rapid influenza diagnostic tests like we can do now from a gargle, a wash, or a nasopharyngeal swab, I would have them produce a little thing, and I would just take a little bit and put it on a slide, put a drop of saline on it, put a cover slip on it, and look at it under the microscope under high dry. Just under a high dry microscope, any microscope that can get a 10x power you can see. And you would see little sheets of 3 and 4 ciliated cells, and the cilia were still moving, and they were coughing up the lining cells of the airway. So there is, the virus attacks the basement membrane and unglues it. So no wonder the irritant receptors of the airway are exposed and that cough is a prominent part. Now, let me say this, there's a lot going on also in the tissue of the septum. If it moves down into the lower respiratory tract, the septum between the alveoli gets swollen, gets infiltrated with lymphocytes, macrophages, some plasma cells, and finally there's necrosis that occurs and hemorrhage into the alveolar spaces, and that means progressive disease. There's usually enough inoculum that a viral influenzaal pneumonia is on the way. And it is very difficult to oxygenate a patient with influenzaal pneumonia despite very sketchy chest x-ray findings. Let me repeat that. You may have little soft, fluffy infiltrates that really you would say, well, there's not any consolidation here. They should be able to be oxygenated on 2 liters. And you've got a 100% mask on, and you've got them oxygenated, but it's taking an unusual amount with scanty findings on chest x-ray. That's usually viral pneumonia, and it's telling you that that x-ray is not sensitive enough to tell you what's going on in the alveolar membrane, across the alveolar membrane, and in the alveolar spaces itself. Influenza pneumonia, in children in particular, causes rapid hyaline membrane formation. Hyaline membranes don't resolve completely in adults. In children who survive influenza pneumonia, they clean it up pretty well, but there's some remodeling of their airways that they're left with. Okay. Symptoms begin remitting within 5 days in most patients. Here's this hiatus I'm speaking about in which the patient feels some better, temperature returns toward normal, malaise is lessening, and then it's followed by the secondary onset of fever, worsening cough, chest pain. Now let me say this. Another form of pain. We talked about the retroorbital pain that influenza causes. We talked about the large posterior chest muscles, the leg muscles that are involved. There's another group of patients who get such severe tracheitis that they get substernal discomfort that's very severe. You think you say, well, they're probably refluxing from their cough. No, if you look, their airway is so beefy, red, and inflamed. They have substernal pain from the influenza itself and its attack on these columnar cells, ciliated columnar cells. Remember that complicating pneumococcal pneumonia is so common that we used to follow death in old people by pneumococcal inflammation, pneumococcal pneumonia, as tracking the spread of influenza. Staph is relatively rare, but remember we see it more commonly after influenza than at any other time in groups. When you see a cluster of staph pneumonia in old people, they've had influenza almost surely. And staph in collectivized nursing homes is fairly common, so they're a setup. They're commensalized with staph, so when the influenza denudes the airway, then staph can involve. Here are some extrapulmonary complications of influenza that we must be aware of. You can have late development of sinusitis and or otitis. It would have to be treated like a secondary bacterial pneumonia with irrigation, decongestants, antibiotics if indeed it is purulent. Many people with influenza pneumonia have to have special oxygenation. ECMO is one of the things we used, extracorporeal membrane oxygenation, or jet ventilation with small tidal volumes in patients with ARDS due to influenza. Let me talk about the central nervous system manifestations. Mental confusion is seen in most old people during the acute phase when their temperature is 102, 103, they're confused. Problem is, you start them on an antiviral immediately, say within 36 to 48 hours of their presentation, and the antivirals that we use can cause mental confusion too. So you just have to get through that. You cannot not treat a person because they're getting a little mentally confused from the antivirals, because this is a deadly virus. Also, those people who have any neurologic disease already, like spinal cord disease, cerebral palsy, seizure disorder, they need to be vaccinated because they have difficulty with cough and clearing secretions, and they do not do well. They're a group, patients with neurologic disease do not do well with influenza. If you look at the heart in autopsied patients, many people have a mild myocarditis. It can be severe and cause fatal arrhythmias. We had a pathologist at Cooper Green Hospital who went home from work with influenza. Jean was a sweet, wonderful pathologist. We checked on her day 2 of her illness. She was sitting in bed. Said I think I'm feeling a little better. She was writing her Christmas cards. Occurred right before Christmas of 1978, and this was the 77-78 epidemic that we had in this country. Okay, and so a couple of days later, she hadn't called in. She didn't answer her phone. They went and checked, and at her autopsy, she had a diffuse, intensive myocarditis and had clotted all of her coronary arteries without significant amount of plaque. She had just developed in situ thrombosis. It can rev up, influenza can rev up the clotting mechanism. You can have a mild nephritis with proteinuria. There's a lot of controversy about the Guillain-Barré syndrome. It is caused by many viruses, including the influenza virus. In 1977, there was a scare that this vaccine that we were using was causing Guillain-Barré, but if we look back at all that data, it was about the same as occurring spontaneously in the general population. And if you add the fact that they had influenza, which causes it, some of those patients had been vaccinated before, and an article or two was written about how the vaccine at that time caused Guillain-Barré. Let me assure you of this. It is more important, don't worry about having Guillain-Barré syndrome from the vaccine. It's much more important that we vaccinate the right people at the right time against influenza. So I just bring that up because it caused a stir, and many people are afraid of vaccines to begin with, but part of the greatest reason that we have increased longevity in this country and all the developed countries is due to the fact that we have excellent vaccines against killer diseases and diseases that maim. Here are the recommendations. They're fairly extensive, but they make sense. So let's go over them very quickly. Healthcare workers, there's a full 30 to 33% reduction in absenteeism when a large hospital system just mandates that their employees have to have it unless they have an egg allergy or or they have neurologic disease. All U.S. citizens 65 plus and all citizens in times of epidemics in multiple countries, if it's spreading from country to country, and we think that if an H1N1, which is what the original swine flu in 1918 caused 100 million people to die, you better, if it's identified early, and only healthcare workers know this, but you would know it, it would be in your literature, and you must advise people of all ages, you need to be vaccinated. This does not just kill old people and youth. This previously healthy people are affected by the H1N1 serotype. All patients with a history of lung and/or heart disease, regardless of age. Now, let me say this. There are two kinds of heart disease that are particularly prone to death by influenza. One is congenital heart disease. A congenital heart disease with abnormalities of flow in the heart. There's something about that predisposes to death, and mitral stenosis. Patients with mitral stenosis who get influenzaal pneumonia die. They just almost all die. There's pulmonary congestion already because of the tight mitral valve, and they do not do well. They do not clean it up. They do not have a normal immune response in the lung. We don't know everything about it, but they're particularly a problem. If you look at absenteeism from schools and workers and numbers of children and old people admitted early in the fall, you know if influenza is in. Those four things, you know influenza is in the community. It's more than just the viral parainfluenza, rhinovirus, coronavirus infections that cause 90% of respiratory infections, okay? Patients who are immune compromised obviously need, any of them receiving chemotherapy or chronic prednisone therapy. Patient with hematologic malignancies should be vaccinated. Infants under 5 years of age, especially those under 2, and pregnant females. In all the pandemics, pregnant women in second and third trimester had a high morbidity and mortality. Those who are neurologically impaired, I've talked about, spinal cord injury and so on. Chronic liver and kidney disease, that makes sense. See, these things make sense to us. Those with insulin-dependent diabetes, extreme obesity. Now, how about the vaccination recommendations? Well, there's pneumococcus. There are two vaccines. They're additive. There's Pneumovax 23 now, and an earlier vaccine. Old people should have had both. People who are living in nursing homes, collectivized, in extended care facilities, they need to have had both, because remember, pneumococcal pneumonia kills more old people after influenza than anything else, not influenzaal pneumonia. Some will have both. Influenza that progresses to pneumonia, then gets a secondary bacterial. Therefore, the CDC, New England Journal of Medicine, big study, recommends now antivirals and antibiotics simultaneously when an older patient with flu begins to develop any kind of infiltration on chest x-ray. Contraindicated against the flu vaccine, egg allergy, prior severe reaction to any component, and then a prior or present history of Guillain-Barré. Obviously, we don't want to take the chance if someone's recovering from Guillain-Barré, it's just there's a small chance that you could aggravate it. That's soft data. Let me just assure you, you don't not vaccine because you're worried that you know of a person who developed it, within a short time after a vaccine. How do we treat it? Well, we must, like with tuberculosis, we must think of all those who are case contacts. The initial case, sentinel case, and case-related contacts in a home, in a school, in a workplace. So that we now have good antivirals that we can give to a person who's not been vaccinated but who has been exposed. Now, remember what I said, who's not been vaccinated but has been exposed. Now, if they've been vaccinated but they're at high risk, that is, they have chronic heart or lung disease, they're very old and frail, they've been on chemotherapy, then we not only start antivirals, but if they hadn't been vaccinated, we vaccinate them. Now, there is one caveat. There is a live attenuated vaccine that you do not want to give to people at the same time that you are treating them with an antiviral. It renders it not effective. But the most common vaccine that we have, which is our dead viral particles from which we've made the vaccine, you can give that simultaneously with the onset of antivirals. So someone has been exposed who is at high risk, but they didn't get vaccinated. So you vaccinate them and start them on antivirals because they have a household contact who has been found to have influenza A. So you see, you do both when you can use the dead viral particle vaccine, not the live attenuated. There's one caveat here with Relenza, zanamivir. In asthmatic patients, influenza causes their asthma to worsen, and you do not want to give them inhaled anything, including antiviral. So you want to use the oral, oseltamivir, Tamiflu, on those patients. Patients presenting for health care within 36 to 48 hours of the onset of symptoms consistent, you start them on it and send the rapid diagnostic test. If it comes back negative, you can stop it. But once again, what if they're a casual contact to a confirmed case? Well, you can start it, particularly if they're immunocompromised or have a high likelihood with heart and lung disease. You go ahead and you start it. Okay, so let's review for just a second. There are epidemics that are local outbreaks that include a certain number of people, so many cases per 100,000. Then when it occurs in multiple countries simultaneously over a 2 to 3 month period, it's a pandemic. Pandemics usually last for a couple of years. That is, all those countries will have at least 2 years. So we said the severe pandemic of 1957-58, that's how we call it, 1917-18. Okay, that's when it killed 100 million people. 1977 was actually 76-77. So it goes for a couple of years. So if there was a pandemic last year and you didn't get vaccinated, go ahead and get vaccinated the next fall early. It should be given early in the fall because it takes some 6 weeks for you to develop as much immunity as you can. Split dose vaccination recommended by some in those cases where you're not sure. There are patients with sickle cell disease, some immune compromise, they're on steroids or so on. You give them a dose, you wait about 3 months and give them another dose, 2 to 3 months, and give them another dose. It's perfectly safe, and it does give a little bit of protection. Remember, no vaccine is 100%, but remember that if it's 60% effective in a population, and even though you might get influenza, if you've been vaccinated, it lessens the course and lessens your chance of having a virulent progressive course. So, in summary, it's a severe infection. It's never to be treated lightly. It's best to treat when suspected. The earlier the better. Recall the high number of people at risk. The young, the old, but remember previously healthy people when it's H1N1 serotype. Vaccination is essential, including for the pneumococcus, both vaccines. Youngest and the oldest and all those with weak immunity have much to lose if not vaccinated and are treated urgently, often together. You are an educator. You must teach this to your patients. They will listen. You're a professional. Thank you. That's my son and me, and Mike Crane may know where that is up in Highlands. I don't know if he does or not, but he's a golfer, and that's a little course up at High Hampton. Mike, you ever played that? Have not? Well, I'll take you sometime. Okay. Thank you all so very much for your kind attention.
Thank you.